Right. So it's 10 past 6. I shall just let a few people keep continuing to do the poll. We'll leave it open until most people have joined. I'm going to stop sharing now. Right. So I'm just going to ask Anna, could you start? Oh, you've done it already. Wonderful. So I'm going to start now. I think we've got enough people to start, and I'd like to say a huge welcome to this our 15th webinar of CamDocUK, talking with the community. Our topic today is autism, all you need to know. So, what about autism? Well, I'm sure all of us have heard about this, but more than 1 in 100 people are on the autism spectrum, and there are around 700,000 autistic adults and children in the UK, according to prevalence surveys. So prevalence just means how many people have autism at the current time that the survey was taken. And however, all other surveys and international estimates have come up with different estimates, and most of them suggest that actually the prevalence of autism in the community is much higher than 1 in 100 people. I'm sure that every one of us here knows someone with autism, so a friend or a relative who is a child with autism, or even a friend who has autism. We may also be parents of children with autism. For too long, it's been some sort of a taboo topic, something we as a community perhaps did not feel comfortable highlighting or even talking about. As a result of this, it's not surprising to read that there is a lack of research about the experience of people from our community. And more recently, we're being lumped under this term BAME, which means Black and Ethnic Minority Groups. It also means that it's harder for autistic people in the BAME community, can sometimes be harder to get the support that they need. So what is the aim of this webinar? The aim of this webinar is to put to bed some of these myths with the help of our very experienced panel here. We have 2 pediatric consultants who specialize in autism, and we've also got parents of children with autism here on the panel. So it is therefore our hope that at the end of this, you will feel sufficiently enlightened and empowered to either help yourself with your children or help someone you know to seek help if they need it. So as I was alluding to, I have a very fantastic panel today, and shortly I'm going to introduce you to our first speaker. But before I do that, I'm just going to see how we're getting on with the polls. So for those that joined after I launched the poll, there is a poll currently on with 5 common questions about autism, which we're going to leave on for a bit while Dr. Kilo is speaking, and then she will take us through some of the answers. So what can I tell you about Dr. Kilo? Well, Dr. Bernadette Kilo, MD, is an autism program manager and consultant for the Southeast Permanente Medical Group. I hope I said that right, Ben. Also known as Kaiser Permanente in Atlanta, Georgia. Dr. Kilo is also mom to 3 children who are on the autism spectrum. So as you can imagine, she draws from her real life experiences, and she also invests her time in promoting autism awareness in the Cameroonian community back home and here in the diaspora. She is the co-owner of the 3Bs Global Autism Consulting LLC, which aims to empower parents of African descent to acknowledge, accept, and act towards getting the required services for their child, navigate the complex educational system, and be better advocates. Dr. Kilo is a graduate from Ross University School of Medicine, and she is well-versed with many US autism state laws. She is also trained and certified in the utilization of Autism Diagnostic Observation Schedule, commonly known as ADOS. This is the gold standard testing tool for autism. And this was not in her bio, but I had to add that Dr. Kilo and I have known each other for donkeys of years. We did actually go to secondary school together many moons ago, and we're proud lessons. So we went to a secondary school in Cameroon called Our Lady of Lourdes College. So on that note, it's my absolute pleasure to ask Dr. Kilo to begin her presentation.
Absolutely. Thank you so much for that fantastic introduction. And it is also a pleasure for me to be here and speak to everyone that has joined in and those who will join later about a topic that I am deeply passionate about, much needed in our community. So thank you, Cameroonian doctors in the UK, for this fantastic opportunity. I'll go ahead and start sharing my slide. Can you see the slide?
Okay, try again.
There we go.
Yeah, that's it.
Perfect. So today we will definitely be talking about autism, like Dr. Bello had mentioned. And what I will cover will be what autism is, the clinical or medical definition of autism, how it's diagnosed, how it's managed, and why autism remains a taboo topic in our community. The medical or textbook definition of autism is that it is a neurodevelopmental delay marked by persistent social communication deficits as well as maladaptive behaviors. When they say autism is a neurodevelopmental delay, what does that mean? What does this look like? If you had to use your mind's eyes to think of what this could be, the best way I can put it is, imagine having to listen to 5 different radio stations, all at the same time, processing every single one of them at the exact same moment, without the ability to tune out or turn down any one of those. Imagine doing that on a daily basis. That gives you a picture of what autism looks like. A lot of times when I do webinars, I always have this slide, always. And the reason I have it is because when I put it up, I ask people, what jumps out at you? Everybody tells me the obvious things. Of course, they see the car, the color of the car. They see the stop sign, they see the color of it. But what people don't pay attention or the minor details that are there is what they miss out on. I have a personal story about this slideshow, this specific slide. So I would need for someone to remind me at the end. But the one thing that no one has ever first told me every time I've put up this slide is the fact that this is an octagon. It's the minor details. See, autism stares us in the face every single day. We walk past it, we see it, but we're not paying attention to it because we're not looking for it. So we miss it. Here in the US, how autism is diagnosed, a lot of times either the parent, the therapist, or a relative, a friend, teacher has raised concern about some of these things that are listed on here. And the child will, or the parent raises concerns to the pediatrician who then puts in a referral to get further evaluation by a developmental specialist. Some of the things that these parents usually complain about are the social interaction. These are children who, when you take them to the park, they meet other kids, they don't play with the other kids. They don't seek out play with these kids. They actually go to the kids to take an item from them, either taking their toys, they're playing by themselves, there are other kids around, but they're more focused or interested in playing with the things in the environment. For example, wood chips. These are kids at the park who solo play. And you also see them doing the same thing at home. They will solo play as well at home. They could interact briefly with another child, but then they retreat and stay to themselves. With communication, these are children who will either take the parent by the hand, they'll lead you by the hand. They use the parent's hand as a tool to grab an item. Some of them will point, some of them may not point. It's inconsistent. You see inconsistency with skills. Some of them could have language. They could acquire language skills early on, and then at some point, it disappears. Some of them could acquire language skills at some point, but it does not progress. It does not expand. And then with the restrictive repetitive behaviors, these are kids who will do routine things. You're taking your child to McDonald's. You tell your child, let's go to McDonald's. And that child knows that to get to McDonald's, you have to turn right. And on that day, you're turning left because there's traffic to your right. And all hell breaks loose in the car. You have changed the routine. They're rigid. You can't change that routine for them. Repetitive behaviors, you will see some children will rock, or they'll rock from side to side on one foot, from one foot to another. They might do stereotype behaviors, like maybe moving their hands in front of your face, looking at objects from the corner of their eyes in a peculiar way. And so these are some of the things that some parents will observe. A therapist could observe it. Even a relative could observe these things, and they start raising concerns about. When a child comes in with some of these behaviors, that will culminate in, once a full evaluation has been done, will culminate to a diagnosis of autism spectrum disorder. How is autism managed? There is the non-medication as well as the medication. For non-medication management, we're looking at things like speech therapy, speech to help with language acquisition. Now, there's one thing I know we commonly do in our community. When you ask a parent, does your child talk? The answer is yes. Well, that parent answered correctly. The reason they're considering talking as a positive or a plus at that moment is because the child can say their ABCs, they know shapes, they know their colors. The question is, and the true question should be, is your child communicating? Now, if your child knows A to Z and Z to A, knows all the shapes, knows all the colors, and can't tell you when they're tired, sleepy, hungry, that's a problem. Your child could have language, but they're not communicating. So speech will help them use that language functionally. So a child who just sits there and says, mama, 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 is not communicating. They have language, mama. Now we need to use mama functionally. Therefore, when we see mama walk through the door, we can go to mama and say mama, or we walk up to mama and touch mama and say mama. In some cases, they may not look at you. It's okay as long as they say mama, then they're using language functionally. When it comes to occupational therapy, we're looking at how it will help the child with fine motor skills. These are kids who, a lot of times, it may look cute if a child is eating with their hands, they're feeding themselves without tools, without utensils. They're feeding themselves with their hands. It may look cute at 18 months. It may look cute when they're younger, but when the child is 6 years old, 10 years old, and they still can't use utensils, fine motor skills might need to be worked on. Adaptive skills as well, you'll need to work on that. That's where occupational therapy. Sensory processing. I think I can write a thesis on sensory integration issues for sure. That is the most commonly not addressed area when it comes to autism. Yet, it is a major issue in autism. And this is just how a child uses their 8 senses to engage the environment. So that must be addressed. And then you have the other therapies like physical therapy for tall walking and feeding therapy. Applied behavior analysis is the only proven treatment or management for autism per science base. So it's the only science evidence-based treatment so far. And then other unconventional therapies that are still in research, and though it's not used, you won't find like prescriptions for these other things. Things like horse therapy, which is the equine therapy, aquatic therapy, music therapy, and art therapy. And then you have the medication aspect of it. Now, the medication is more to address some of those things that come with autism, not addressing the autism itself, because autism is the foundation, it's the underlying problem. And so most children who have or who are on the autism spectrum have challenges with sleep And so they will give medication for the sleep to help address the sleep, and also for maladaptive behaviors, which will include aggressive behaviors. So there isn't a one pill for autism. Why is autism a taboo topic in our community? So many reasons. But the main ones I want to focus on is culture, the role that culture plays. Some things in our culture, whether it's an individual culture or a culture as a whole at large, there are certain things that keeps us away from either understanding or getting a good grasp as to what autism is, or even recognizing it or acknowledging its existence. Religion also plays a role. What we have, or our minds have been shaped to understand what is perfection. And so when we're looking for perfection based on what religion has instilled in us, then of course, we tend to deem certain things as good and other things as evil. Access to educational information. But with all of this said, the one thing I know for sure that helps or promotes or enables some of these stigmas that exist is the history. In the words of Bob Marley, if you know your history, then you know where you come from. You must understand, one must understand the history of autism in order for you to understand why the stigma in the first place exists in every society and every community. Two, understand why you as a person have little or not a good understanding of what autism is. And if you would allow me to take you through a historical journey of autism. First, there was schizophrenia, existed only in adults. Then they found a few kids that would present with similar behaviors as a person with schizophrenia. For example, just staring into blank space. They had no emotional, you couldn't read the emotion on the face. They were expressionless facially. They seemed not to have any type of social emotion. And so when they found that there were children who were presenting with similar behaviors, they came up with a diagnosis called infantile schizophrenia. Now, think about this. How scary it could be for a parent to have an 18-month child diagnosed with schizophrenia. It made no sense in the medical field. At that time, that's what they had to call it. But then 8 years after that, they looked into it and they were like, wait a minute. This scientist realized that there were adults with schizophrenia who actually had certain behaviors that will cause them to withdraw within themselves. So they were more self-absorbed. That was when autism was used as an adjective. It was not a diagnosis yet. Moving on to 1943, infantile schizophrenia, because it made no sense for an 18-month-old or even a 13-month-old to be diagnosed with schizophrenia, was renamed as early infantile autism. Then, years later on, the scientists in Germany described a milder form, and they called it Asperger's. This is the reason why the term high-functioning autism, this is how it was created, which, by the way, is problematic and very offensive to people in the autism community. In 1967, autism is now classified in the International Statistical Classification of Diseases. Autism now they put autism under schizophrenia. So it's still in the mental health disorder textbooks. And then the good thing is, as research is advancing, they find out that there is a genetic component to autism. And that was first published in 1977. Years later on, infantile autism is now removed from underneath schizophrenia. So it's no longer a subcategory of schizophrenia. It becomes a stand-alone diagnosis by itself, but yet remains in the mental health disorder textbooks. Then infantile autism becomes replaced with the word autism disorder. And doctors get provided with a checklist, including psychiatrists and psychologists. They now get presented with a checklist of these are the things that the child will exhibit. And that was how that diagnosis came about. How I like to put it, and this was from my coworker, Leslie, who put it in a beautiful way. I like to think of these 4 things as siblings. A lot of what I have mentioned before, keep in mind, it was diagnosed in infants, but they started realizing that there were children from age 0 to 3 or 3 to 4 that were exhibiting, they will have certain skills. So for the child who disintegrative disorder, these are children who had certain skills and then they lost it. And then you had the pervasive developmental delay, Asperger's, Rett syndrome, all of them presented with the exact same characteristics, every single one of them, social communication delay and maladaptive behaviors. But they were in different places. It's like you would find them in different areas in one textbook. And so this one scientist said, hey, think about this. Well, the way my coworker put it was, think about it this way. You have siblings in different homes exhibiting the same traits. So they had to find a mother, a house for them. And so they found a house and called it autism spectrum disorder. This is how the word spectrum came into the diagnosis. And so all 4 of them, or 5 of them, actually 1, 2, 3 of them moved into autism spectrum disorder. The only one that was not moved into that disorder was Rett syndrome, only in females, and because there is a direct genetic link to it. Autism may be hard to see, but it is not invisible. So I will encourage everyone to practice compassion. It's there. We see it every day. We come across it every day, but we miss it because we're not looking for it. That concludes my presentation. Thank you.
Thank you so much, Dr. Kilo. You did ask us to remind you about that picture.
Absolutely. Thank you for doing that. So this slide, I wanted to talk about communication. Autism is just another language. We, as of African descent and other immigrant families, we come from homes where multiple languages are spoken. In saying that, autism is just another language that you too can learn if you only choose to learn it. And so this stop sign, I know a young fella, every single time his mother will come to this stop sign, she would always speed past it. It's like the stop, it clearly says stop, but the mother will never come to a full stop. She would look left and right from a distance, and because there wasn't any car, go past it. And so one day, this mother is driving, and that stop sign, before she gets to that stop sign, the little child in the back seat says, octagon, octagon, octagon. And she's looking around because all he ever said was shapes, and this mother could never make sense of it. They'll be walking somewhere and he'll say triangle, triangle, and she will not understand. And so child kept saying octagon. For 1 year, this child would say the exact same thing every time this mother got to this stop sign. And on some day, she looked at it and she's like, wait a minute, why is it that every time I get here, the only thing this child says is octagon, and then he never says octagon again. And then it dawned on her that that stop sign is actually an octagon and that the child is actually saying stop. Now this child is hyperlexic, can read stop, but for some reason, the best way to communicate was to use the shape of that stop sign. The young fella I speak of is my first son, and the mother who drove past the sign, luckily I never got a ticket, is myself.
Wonderful. Thank you so much for that, Dr. Kilo. Thank you very much. Autism is just another language. Children with autism are just speaking another language. We should learn how to speak that language. Beautiful. And what really struck me was the fact that, you know, we just think autism has been there for a while. It's not actually been there for a long time, has it? And obviously, with the fact that we've only kind of learning about it, I can imagine that, you know, we would be only learning how to deal with things. And that's why we have webinars like this, so that we can keep on educating ourselves about what to do, and to just know that actually it's not a mental health disorder like it was put on the schizophrenia. It's certainly not that. Well, Dr. Kilo, you do, there's many questions on the Q&A. We're not going to be able to go through them all right away, but the first thing I think Dr. Bennett would want me to do is to ask you to go through the poll.
Absolutely.
Yes, I don't know if you've got access to that.
Yes, I do.
Yes.
Absolutely. So the question is autism a mental disorder? It is not. It is a neurodevelopmental delay. It's not a stagnation. The neurological system, as a matter of fact, in embryology, in human development, is actually the last to develop. So think about it this way. If the last system in the human development is already the last to develop, and then it gets delayed, so it's like a delay. So it will progress. It's still developing. It is not a mental disorder. Unfortunately, it is in the category by itself, but yet remains in the mental disorder textbook, which only enables and promotes the stigma we see.
Interesting to also note that, you know, about a third of our attendees actually thought that it was a mental disorder. So very good education we're having today. Next question was, are children with autism being deliberately uncooperative? I think we had better answers to that. Yes.
So, and the answer is false. That is true. They're not. A lot of things is not within their control. They can't control it. I know a lot of times, and this goes back to the crux. What is the base of what autism is, and the thing that actually is the driving force of some of these behaviors that we are noticing and seeing. And research has shown that it's the sensory processing or sensory integration issues. A lot of times they only talk about the 5 senses, but to be honest with you, we have 8 senses, and 3 of them a lot of times they forget it. The 5 of them, we all know it. The vision or sight, we have auditory, smell, taste, tactile, touch. The other one, balance, we forget it, that's vestibular, proprioception, one being aware of one's body awareness. These are people that will just walk and bump into you and you think they did it intentionally. No, that person has no body awareness. They don't know at any given time. Me and you can close our eyes and I can tell you exactly where my knee is positioned as I'm sitting. Someone with autism who is affected in this way, especially if proprioception is affected, has no awareness of where their knee is. They can't tell you with their eyes closed. And then the last one that is also forgotten under the sensory is interoceptive. When you and I are hungry, there is a signal. Either you get this hunger pangs, your stomach crunches, you get aches or something. So you and I, we know what to do. We hear the growling and we stand up, we go get something to eat. A child with autism may just stand up and start running back and forth. That's interoceptive. A lot of times interoceptive, we don't see it. The child who covers their ears to no sound, it could be interoceptive.
Okay. Very interesting. And number 3, most children grow out of autism, so we tend not to see adults with autism.
False. That's correct. The answer is false.
The answer is false.
Children who have autism grow up to be adults with autism. You can outgrow certain mannerisms. You can outgrow certain difficulties, but the restrictiveness is there. The depth of the repetitiveness can be toned down. Social communication still will remain a challenge. They could still communicate, but that social interaction could still be a challenge. So the depth of it may not be as obvious as when they were younger because of the therapies that have been put in place, but it's still there. Children with autism,
yes.
adult autism, absolutely.
And the autism affects more boys than girls?
That is false. The understanding is that it affects more boys. No, the research was done mostly in boys. All the research for the past 40 plus years has been done in boys. As a matter of fact, the diagnostic criteria for autism today is based on research that was done on boys. Hence, the girl child is diagnosed later. It does exist in the girl. Majority of the girl children get diagnosed at age 8 unless the repetitive behaviors and mannerisms are so severe. That's when they get diagnosed early on. But it is this, they get affected as much as boys.
All right. And the last one, before we move on to our next panelist, autism tends to run in families?
Yes, there is a genetic link. Absolutely. So far, 400 plus genes have been found linked to autism. Some families, you may not have known about it from great-great-great-great-grand, but it's been there.
Wonderful. Thank you so much. I hope that you all found that poll very interesting. There's many questions on the Q&A, Dr. Kilo. We'll come to that at the end so we can get our next speaker on, who is Dr. Ayesha Qureshi. Dr. Qureshi is a consultant community pediatrician in Birmingham. She is her words, local West Midlands girl who studied at Birmingham Medical School. Her first house job means the first job we do as doctors, was in Wolverhampton, where she met her husband. And this was her introduction to the Cameroonian community in 1995. And I've added this, that her husband is in fact one of our CamDocUK members, and you may have seen him moderating one of these webinars recently. Her pediatric training was in the West Midlands Deanery, and she took time out for training in adult psychotherapy. She has been a consultant for 13 years, and in this time has been the named doctor and the designated doctor for safeguarding, and a forensic pediatric SARC, which is Sexual Assault Referral Center examiner. Currently, she does a specialist ADHD clinic and specialist autism assessments using the 3DI and ADOS, which we spoke about before, Autism Diagnostic Observation Schedule. She is involved with the Royal College of Pediatrics and Child Health Global Team and has done previous field work in Palestine. Dr. Qureshi, the floor is yours.
Thank you very much, Dr. Bello. Thank you so much for inviting me to speak this evening. Good evening, everybody. And I'm really grateful to Dr. Kilo for setting me up so well with her brilliant talk on autism and actually saying a lot of the things that needed to be said. So I'm going to try and share my slides so we can get started.
Dr. Qureshi, do you want to share again? Maybe and start from the
beginning? Yeah, this happened last time, didn't it? Let me try again.
Yes.
second, I don't know why it's not letting me share the screen. We checked this and it worked earlier.
Yes. Can you see the button that says share screen?
Yeah, I tried this. Not letting me do it. Hold on, let me try again.
Yep, you started to share. There we go. And then you just need to start the slideshow.
It's doing that thing.
It's doing that thing. Okay.
One second. Let me just, my husband is here. He might be able to help. 1 second.
Lovely. So in the meantime, Dr. Bene has also got your presentation. So she'll get that ready for you, and we can answer one question, which I'm going to put to Dr. Kilo while we're sorting out that. So what can we do as parents for challenging behaviors? This is from Liz Mahachi. What can we do as parents? Dr. Kilo.
Absolutely. So as parents, in terms of challenging behavior, the first thing you want to do is always assess the functionality of that behavior. So there are two ways to approach this. One, the question is, when are we noticing that behavior? What is the antecedent? Why is this behavior happening now? Are we noticing it frequently at around a specific moment, time, place? So you're assessing what is happening before, what's the trigger? Two, what behavior is being exhibited when that behavior happens? I've seen some kids hop like frogs when there's a weather change, and that goes with barometric pressure, sensory integration right there. And then C, what are the consequences? Consequences, I don't want you to think of it as something bad. It's more of what did you do? Because the consequence can actually enable a behavior. So you have to assess the functionality of that behavior in the first place to be able to address it and understand it. The other aspect of behavior is when you're faced with a challenging behavior. Now, the reason it's challenging is because you're not speaking the language. I speak French, you speak English, we're talking to each other. Of course, I will get frustrated because we're not understanding each other.
Okay,
So
Dr. Kilo,
yeah.
Sorry to cut you, just Dr. Ayesha has got her thing.
Absolutely.
And there are many questions regarding that in there, and perhaps start looking at the question and answer. But what we're going to do is try and get to everyone's question and just give a brief answer, because there's many questions in there. Dr. Qureshi, we're there.
Yes, thank you. I don't know what happened, even though we practiced this, but anyway.
We practiced it several times, yes.
So here we go. So thank you for inviting me today. Thank you for that introduction. So I'm going to talk about the UK approach to autism assessment, referral assessment. And I am a community paediatrician, as you said, and I think even medical colleagues may not have always heard of this specialty. And essentially, I'm a paediatrician with a special interest in development. We call it neurodevelopment, but development, it's the same thing, and also in safeguarding. And one of the reasons I'm passionate about this specialty is I hope it's more a holistic specialty within pediatrics, which I enjoy. So I'm going to see if I can move my slides. Okay, so let's, so as I said, building on Dr. Kilo's excellent talk, if we're building a profile of a child who has developmental differences, and if we're talking about autism specifically, we're looking at the whole picture. And as Dr. Kilo pointed out, there are specifics around autism that we are considering related to their development. Now, one of the things I wanted to say about autism is when we talk about an autistic spectrum disorder, sometimes this word disorder can be a bit scary, but actually it's actually, for me, it's just describes a profile, essentially. So when we're looking at development, you can look at all areas of development. And, you know, you might be looking at whether a child's walking, talking, how they're interacting, their fine motor skills. And from a point of view of autism, the reason it's a disorder is because often it's not a global delay, i.e. I can't say that a child is 12 months from expected in all areas. Essentially, sometimes they can be age expected for certain areas, such as their motor skills, for instance. And even at certain stages with their speech skills. So I don't want people to be scared of this word, disorder. I want to sort of debunk that a little bit. It's essentially relates to a developmental profile. And when we're looking at a developmental profile, we're looking at all the aspects of it related to the other areas of development, the physical and emotional health, and a child's functional abilities. Social situations can make a big difference also to presentation of children with developmental delays. For instance, if a child has undergone trauma, I see children who come through the safeguarding route. There may be children living in deprivation. And sometimes these anxieties, although you can have children who have autism who have significant anxiety as well, but we need to look at the whole picture. So sometimes selective talking, for instance, which is an anxiety-based disorder, we need to work out what is actually going on. And there can be an overlap between a lot of these developmental conditions. To come back to the core features of autism, one of the things is obviously communication, as Dr. Kilo said, speech and communication, two slightly different things. And it's important to know, this is generally how the under threes, the younger age group, come to light. And often these children have the more obvious and significant deficits with their communication. And I think these children, it's really important to identify early. So these are the children that families may be discussing with professionals around 18 months, 2 years old, because by this time, they haven't acquired the speech milestones you might expect for age expected. And this subset, because it's a spectrum and it's a wide range as discussed, this subset I think are the ones that present earlier, and they may have more of a global picture related to their learning also, and it's very important for them to be identified with speech delay or the cruel aspect of speech regression, where you felt your child had already started progressing with their speech, and then there appears to be a slip back in those areas of their speech development. And some children, talking about functional abilities, present later in school age. Now, often these children have developed their speech skills, but what happens is when they get to a certain level, as children's development progresses through stages, they become a bit stuck, if you like, as their peer group progresses through their stages of interactive development and social development, and that's when their neurodiversity may become more apparent. And in some ways, these can be mild or moderate forms of autism. And I think that one of the important things is to remember that you can have a milder form of autism, but it can still create significant difficulties for a child within a school environment or a social environment. So it's important to remember that. High functioning autism. So there are two classification systems, the DSM that Dr. Kilo talked about. There's also another one. I don't really want you to be bogged down by these, but the ICD. And actually, if you're talking about higher functioning autism, it isn't always about high intelligence or about a special skill. Actually, in some of the classifications, it's just that you had normal speech development until the age of 3. So, you know, sometimes parents will ask me where on the spectrum a child is, and that can be one of the defining factors where their speech was at 3 years old. So what happens? So to talk a little bit to us, as the colleagues who might be referring a child in, often it's the GP, and to parents about when you might take your child for an initial concern or assessment. Essentially, to meet the criteria for assessment, you do have to show the developmental differences in at least 2 environments. And sometimes it may be a speech delay that often can come good. So there are isolated speech delays that often do progress between the ages of 3 and 4. So it's it's the whole picture. Referrals will come if they are seen in 2 environments, the differences in the social interaction and communication, if there are associated difficulties that may come alongside the autism, if there's school or nursery concern, and if there's family history. Families may already know what they're looking for, and that might also help with a referral. So what happens? So I'm talking here about Birmingham, and I hear it's similar from people that I meet in my specialty, but there are differences locally speaking as well. So initial input would potentially be from your local professional, particularly the under 3s may come by a health visitor. And the health visitors in the UK do the developmental assessments. So they may refer a child in, or a parent may go to a health visitor and say, I'm concerned about my child's play skills or their social skills, and that's how they may be highlighted. A SENCO is a special educational needs coordinator who is present in nursery schools as well as primary schools and even secondary schools. I do get referral for teenagers as well for autism. And they are often very skilled at knowing about development, particularly the nursery school SENCOs, and they can also do direct referrals to our services, actually. There may be a family support worker involved, depending on the social situation of the family. And these are all professionals that can be helpful to the family. Sometimes people will go directly to the general practitioner, or sometimes these professionals will refer in. Like I said, in Birmingham, the neurodevelopmental services, i.e. the service I work for, will do the assessments around autism and ADHD. In some localities, it may be CAMS, which is Child and Adolescent Mental Health Services. So it will depend on your particular area. The reason you have to come to these services is it is considered a medical diagnosis, and there is a need for a medical review for this child before they go through any further assessment process. And what is the medical review for? Now, I put in the side of this slide something called NICE. So this is national guidance for review of any medical conditions, and autism has a NICE guidance for children being assessed with autism. It is required that it is a multidisciplinary process. You should not receive a diagnosis of autism by your child being seen once. It should be a more detailed process than that. The medical review is actually to look for other things as well, because it's not a condition where we can do a blood test to say, oh, your blood count is this, therefore you're anemic or you're not. You have to match it to a set of criteria. So it is important for the medical review. It may be there's restricted eating, there's growth restriction, it may be there's certain features that appear in the child that means we want to do more genetic testing or other things that need to occur. So it is very important that a medical review with a specialist does occur. All of that done, it may be that the child is then referred for a multidisciplinary assessment. In my team, they're referred to therapies called neurodevelopmental pathway. And at the end of that assessment, if a diagnosis is forthcoming, or even if not, there will be feedback to the family and counselling. And if there is ongoing medical conditions, they will then be referred back to the consultant clinic. The team will also direct the family to local services. I'm just going to take a step back to the consult with a paediatrician. I am aware when parents come to us, it's been a long journey, and this is an important part of the journey. And I often feel that when they come to us, they've had these concerns and worries and fears. And sometimes you're actually validating this by saying, yes, your child needs an autism assessment. And I think it's very tricky because it comes with relief sometimes from families to say, somebody's listening to us and our fear, we were right. But on the other hand, it also probably starts the clock a little bit more definitively on the grief process. And the grief process is obviously your child is still there, but mourning their normal development. And it's a process. And, this diagram shows that it's not a straightforward process. You can go around a loop and back again, and it's ultimately coming to some level of acceptance. But I appreciate it's a very sensitive time for a family, and they may have their own concerns about stigmas, about labeling, and lots of things that go alongside that. Further follow-up may be for medical management of sleep, further assessment for other conditions like attention deficit and hyperactivity disorder. It may be you're referred into CAMS again for mental health support around anxiety, OCD type symptoms. Within our service, we would refer to occupational therapy, or for occupational therapy advice, as Dr. Kilo said, about sensory processing is integral to the difficulties in autism. And then a little bit about education. So the children I talked about who present early really need to get into the system so that they can be assessed related to their level of learning. And it might be they need extra help through a thing called an education healthcare plan in the UK. This is a specific legal document produced by the local authority in order to describe a child's health and education needs, and needs to be reviewed on a yearly basis. Children who need to access specialist provision or special school will need one of these. They cannot access special schools without this document. And sometimes if your child is in mainstream school, because you can think if the difficulties are more mild, do we need a label? Do we not need a label? But I'm told by SENCOs at school is that we need to justify resources being directed towards your child. So sometimes this diagnostic label can be helpful. It would be lovely, I think sometimes, if you could just help the child without necessarily labeling it, if it was that it was not necessarily helpful to label. But this is what I'm told by schools. So it's really important, particularly for the children who are potentially non-verbal and need support for independent skills, that these processes start early. And this is a quote from a mother I saw in clinic a couple of weeks ago, and she was telling me, as hard as this is, she would have it no other way. She said, honestly, doctor, I would have it no other way. My child has helped me see the world in a different way. I jump in puddles with him and I enjoy the present. And it was lovely to see the relationship between her and her boy. I think that there's a question that parents ask a lot: what does the future hold? What is prognosis? And it's not something I can say, and I'm very honest with families about this. It will depend a lot on all the associated conditions. And like I said, sometimes even the milder forms of autism can mean there are significant sensory difficulties or other things. However, I would say there's always hope. There's always a chance to progress, and with the right support, children can progress. And I have seen children who have autism go on to further education, go on to employment, and actually, if reasonable adjustments can be made, these children and young adults are covered through equality and disabilities law, and it's really important to understand that and for them to know their rights related to this. There is we do direct people to certain resources, and these can be posted in the end. And I could talk about autism for hours. as Dr. Kilo was saying, sensory processing itself could take a day. So I'm going to leave that there, and we can talk about further things in the panel.
Wonderful, wonderful. Thank you so much, Dr. Qureshi. Thank you. You're going to stop sharing your screen. As you were speaking, there was a question that came up about the fact that autism assessments were being done by the mental health team. So that was asked by Waters, and I'd just like you to just corroborate that as well. He says, why do we usually receive ASD children and young people to the mental health service for therapeutic treatment? If you can just answer that again. I know you did in your talk, just in case that was missed.
Sorry, as in what reasons may they present to mental health services?
Yeah, why they sent specifically to a mental health service, yeah.
So like I said, for instance, from my clinic, we would do the neurodevelopmental assessments, but we might refer to mental health services if there were associated anxiety, yes, OCD type symptoms. Yeah. Sometimes if there's a self-harm and behavior that challenges, I can treat ADHD, but I would not necessarily use psychiatric medications, and sometimes they just need very detailed psychology input and support. So that would be the reason. That would be the reason.
Perfect. And we have a question that came in from Liz, saying, is medication the best option route? I think Liz's daughter has got autism. She did write that before. Is medication the best option route? I don't want her to take medication for challenging behavior. Is there anything I can do to make my child calm?
So from a point of view, I know Dr. Kilo talked about behavior management, and I think that is key. Now, the British guidance doesn't talk about a formalized number of hours of ABA, and I know in America it's slightly different related to ABA. Here, what we think is that there should be a approach of behavior analysis within schools. And then also what I found with behavior that challenges, when I refer to CAMs or learning disability teams, they will sometimes do very detailed work to try and work out what the triggers are for the behavior that challenges. And sometimes this can really be key in trying to sort out the difficulty. For instance, we had a child at mainstream school, and this is just a small example and may not be relevant, but just to give an example. And at lunchtime, we were told that he was attacking the girl he sat next to at lunchtime. And we didn't know why this was happening. And when our early years teacher went in and made some inquiries related to this, it turned out that this little girl used to hum. And when she hummed, when she was like singing and humming at lunchtime, poor thing used to get attacked with a fork by this little boy who she thought was her friend. But it turned out that his sensory overload with the humming was just too much, and that he couldn't verbalize that it was too much for him. And so sometimes identifying the triggers can be so important in trying to sort out behavior that challenges.
Okay, there is another question on there. I was wondering, Dr. Qureshi, if you could type the answer down for Pat. Pat has asked a very detailed question about applied behavior therapy. How does it work? What's the defined success? What's the success rate? How long does it take to notice the results? It might be one to just type out for him. And if anyone else is interested in sort of reading the answers, it'll be in the question and answer box just for the purposes of time management.
Linda, could I ask Dr. Kilo to discuss that? Because like I said, we don't I do have families that use ABA through private therapy, but it's not something we use as a regular.
All right, so maybe Dr. Kilo will help me answer that can answer that for us. And just one other thing, Jules asked this question first, and it may look like I've been ignoring him. No, Jules, is stem cell treatment not an option? He's written.
Stem cell treatment to treat autism.
Yes.
This is not something that is currently in any guidance or being used. Although the genetics of autism are becoming more and better defined. So I don't know what the future holds related to treatment, but currently it's not a treatment that we are using or has any way be ratified to use.
Thank you very much. Thanks again, Dr. Qureshi. I mean, there's many questions on there, which I'm going to come back to ask you at the end. So thank you very much. Really enlightening, really nice to see differences in between the UK and the US. Our purpose for today was to give you an overview in the US and the UK. And also, Dr. Kilo is just going to tell us very briefly about what's happening in Cameroon. We were hoping to have a doctor from Cameroon, but you may have heard about some light issues and some broadband issues. So Dr. Kilo is going to very kindly sort of tell us what's happening in Cameroon. And there is a question on there which I think you might be able to sort of put into it, because an attendee there has asked, do you think the environment can be responsible partly for autism? Some parents say that they've solved their mild autism in their kids by sending them to Cameroon, and believing interaction with others play a major role in progression of autism. Can you comment about this and how true it is? So if you can just tell us about what happens in Cameroon and maybe answer that question, I can repeat it again. Thank you.
Absolutely. So in Cameroon, when it comes to autism, there isn't a formal diagnosis or one person that is doing this diagnosis. And so a lot of kids are going undiagnosed, and there's no access for anything, whether it's formal diagnosis or helping the parents understand what this thing is. A lot of awareness is being raised. So there are a lot of families that are coming up now and discussing that, hey, I'm seeing XYZ based on some of these webinars that are out there, such as this one. And so there isn't, pretty much there's nothing, but there's work that's ongoing to help these families and actually help these children as well. In terms of, can environment play an issue? And I want to address that from two angles, in terms of how the person who posed the question. I think I'm understanding that, does environment play a role in the causation of autism?
Yes.
I want to make sure I understand that.
I think that's what
absolutely.
He or she. Mm-hmm.
So that is a theory that is being looked into, because nobody knows exactly what that one thing that's causing. We can't pinpoint specifically what's causing it. And so that's one of the theories, is environmental, because there is a genetic link. And also for those children who actually get the diagnosis of autism, there's an idiopathic. So it's unknown, that the cause is unknown. And so, yes, they're looking into it. Even though environment, they have not done that much research to pinpoint and say, okay, maybe people in this environment or XYZ could be predisposed, and why. That, to be honest with you, is something that I think the research community needs to look more into. But yes, it can. In terms of people who have sent children back home and they've noticed a progression, there is a possibility for that, and that goes into neurology. So if I had to use neurology to explain that, is in the Western world, the way our system is set up, we go to work, our kids go to school and come back. That back and forth, the only people on new things they're exposed to is school and home. There's really nothing new on that path. If you look at a child in Cameroon, from the moment they wake up to go to school, they have 50 aunties or uncles who have just stopped by in the morning. You know that, auntie or uncle that just stopped by. We don't call to tell you we're coming by. We just stop by. And then you leave, you take that child to school, they're exposed to new. So it's the number of things a child gets exposed to. The more they get exposed to, the more neurological pathways you increase. And the more neurological pathways you increase, you help the child. What? It was a neurodevelopmental delay. So you are enhancing neurological development in that child. That is why there is a possibility. But at the end of the day, there's still that deficit. Social communication will still be a deficit.
And as far as you're aware, are there any special schools in Cameroon for those that have autism? What should parents be doing, with their kids? If we don't have any doctors like yourself and Dr. Qureshi, what should they be doing? Should they be finding people to help with the communication skills? What kind of advice can you give parents of children with children that have autism in Cameroon? Should apart from watching this, what other things can do? I know you're personally involved with trying to educate some doctors back home, and what should they be doing?
Absolutely. The community must come together and figure out how to help these children. There isn't a roof or a center that we could say, this is the autism center, and you walk into the center and you get help. There's a lot of organizations in Cameroon that are trying to help these kids, even though they may list it as an autism center, but they cater to every type of disability. Keep in mind, autism is not the only disability that exists in Cameroon. You even have children with Down syndrome who struggle. The parents don't know how to help these kids. So there are a lot of disorders in Cameroon that these children are not getting services for, but there are a lot of other organizations that are doing a fantastic job. Can Abilities, I think Mr. Angafor will speak more about this, is doing a fantastic job in Cameroon in not only helping the children, but helping the parents. And so when you have caretakers like this, then they're able to train them and they get the word out there. They train the next person. So this has to be ongoing. Webinars like this and also hands-on in Cameroon will definitely make a difference. It will help out.
Wonderful. Thank you so much, Dr. Kilo. We'll come back to you, I'm sure. I'm now going to introduce our next speaker. His name is Mr. Giddeon Angafar. Giddeon is a community champion, an autism advocate, and autism parenting support mentor. He is the co-founder of Can Abilities Foundation, an autism advocacy charity which he and his wife founded. He has a wealth of experience in autism parenting and in the support of individuals living with autism and their families. He has previously spoken about autism and culture and the experiences and challenges faced by African diaspora families whose siblings are living with autism. He sits on the Neurodiversity Strategy Group for Hampshire and Thames Valley Police, where he helps to advise and shape strategy on the employment and support of people with diverse and challenging needs. Giddeon, the floor is yours.
Thank you very much, Dr. Bello, for that elaborate introduction, and thank you for having me. I had some slides, but due to technical issues, I believe, okay, thank you for helping drive that for me. So I will be speaking on autism parenting, challenges and hope. That's just the key outline there. I'll give a brief introduction and talk about the main challenges, but also express a few, as my co-panelists have said, a few things about the future. So to start off with, all what I'm basically going to share here is experience of 17 years of parenting a child who lives with autism, but also some of the story of the journey we've had with parents, as my co-panelists has rightly said. So I'll start with the question. So why is autism described as a spectrum? I think both Dr. Qureshi and the rest have expressed that it's a spectrum basically because it's a lot of the things you see on the screen and more. So it's maybe to do with repetitive behaviors. It may be about social awareness, verbal or non-verbal communication, information processing, and much more. And this in itself it complicates or puts further challenges on parents, particularly, and practitioners as well, because the story of one child is not the same for the other. And because they exhibit all these different sorts of, as Dr. Qureshi said, profile, not disorders, then it can be very difficult to box that into one thing. And that's why it's described as a spectrum, because they portray different characteristics, and this can be challenging. One parent, for example, who may have autistic children, they may not necessarily do the same things. Their symptoms or the way they act may be slightly different. And that can make it a challenge in itself. Let's move on to the next slide, please. Right, I'm going to spend a bit of time here to unpack some of the main challenges that parents face. One of the very key challenges is actually about assessment and diagnosis. As it's already been discussed, autism is not one of those things that you can do a blood test and say, yes, this child or this person has autism. And it's also one of those things that may be very difficult because you have to put profiling, as we say, maybe about behaviors, it may be about attitudes and all that. And some of these take time to develop. And because of all these difficulties, it makes it difficult for practitioners to actually just say, yes, this child has autism. We know, as it's already been discussed, health workers, schools, pediatricians will basically need to look at, observe over a period of time, compare notes, and conclude that, yes, this person can be diagnosed with autism. So if it was something where you could do a blood test, as it's very easy, take a temperature and say, yes, this person, because their temperature is at this level, they have a fever, then that would actually make it much easier. So that in itself is a key challenge for parents. And when this happens, it's also very, very difficult for the parents because they are seeking for answers which are not immediately visible at that time. The second, and I would say one of the most challenging, is actually about once that diagnosis has been established, it can be very difficult for parents to accept and come to terms with that. And I think we've spoken about this as one of the co-panelists mentioned in the stages of grief. This is something that from a personal experience I went through. When a parent is actually expecting a child, this parent they have dreams, they have hopes, and they begin to plan and kind of visualize the sort of thing that they would like to do with their child. When the child is born, you cradle the child. Me personally, when I found out that our child was going to a boy, being an ardent footballer, I kind of dreamt of taking him to football, talking football with him, and sharing all those. But, you know, it never turned to happen. And because of that, I was kind of stuck in grief. I became very angry. And at some point, I would actually say, no, this is not happening. And, you know, being depressed about that and bargaining, oh, why me? This is not the child I expected. Can I have a different child? And ultimately coming to that point of actually saying, yes, this is the reality. I need to accept, appreciate, and deal with that. And when parents get to that point, then the burden becomes a bit lighter, but it's a journey that for some can actually take years. And sometimes all these things happen concurrently. For some, you know, one stage may happen at a time, but until they get to that stage of acceptance, it becomes very difficult. Even when parents accept, because it's something that you deal with for lifelong, then they can actually literally go back to some of those issues again. Another challenge that is very prominent is barriers to or obstacles to or services. In the UK, for example, there are different health authorities, there are different councils and all that, and the services are not joined up, if you like. So there's no sort of synchronized services. So while one practice or one local health authority, one health authority would do things, another one would do it differently. It comes down to services as well. And as Dr. Qureshi said, a lot of services, particularly councils, need to justify why they have to spend this money and services, because they are tied as well. You find that parents, especially those who cannot actually articulate the stresses and strains they are going through, or one where the resources are readily available, they may be able to cater for the needs of the child and the parent. While in other councils or other health authorities, it's very difficult where finances are tight and that, then this leaves the parents in limbo. And it can, in some of those parents that we know, some of these can lead to very long litigations where there is a court battle saying this child obviously deserves this because, you know, they have actually been diagnosed of this and they should really be provided these services. And when that happens, instead of caring for the child, the parents who are already very stressed are spending a lot of time going to court or having reviews about things that really should be done. I know that Dr. Kilo already, sorry, not Dr. Kilo, Dr. Kilo already mentioned about the cultural and religious attitudes. Within our community, we come from a culture where autism is, and even a lot of the disabilities sometimes are regarded as the result of occultism or witchcraft. So we have, for example, even within our communities, people who would readily go to work, care for children who are autistic, come back within their own communities, and you know, they would look at the child there or call names. We've heard names used, Mumu Ngombe and things like that. When in actual fact, these are cultural things that are creeping into that, and these in themselves cause a lot of pain to parents. We've had situations where within some of our communities, parents have been asked to bring their children to church so that the demon can be cast out of them. They can pray for them, and you know, so that the child will not be autistic anymore. And these cause a lot of issues for parents. They actually break relationships and things like those, and they can be really they sap confidence out of parents and their families. I did talk about finances in terms of the services, but parents, especially the parents who have children with very challenging behaviors, as we see in our journey with CAN abilities and in our own personal journey, sometimes these parents are actually the breadwinner. Within our communities, we know there are people back home, families relying on you for sponsorship, hospital bills, and things like those. And these parents, in some of the cases, is only one parent who is working. We've seen situations where one parent is working about 3 or 4 different jobs just to make ends meet. There may actually be, you know, carer fees to pay, and sometimes what some of the services offer are not enough. And you find these parents not able to meet up with their financial needs and really working themselves to death because of that. We also move on to things about, I'm going to join exhaustion there to talk about the stress, the trauma, and mental health. A lot of parents who have children who live with autism, especially those with challenging behavior, some of them end up being stressed, some of them end up with mental health issues. Sorry, if you go back again, please, just a bit. They end up with mental health issues because they are struggling to cope. If these parents have, I think when we started, my initial slide had the image of the family. If these parents have siblings, the siblings, other siblings need to be catered for. So if you imagine the child or children with autism, you spend a lot of time with them, but also the one who is not also needs attention. And a lot of these juggling with that and struggling to do that, the parents end up being stressed. They end up actually having a mental breakdown. Apart from that, I think we've mentioned stigmatization again, and particularly within our diaspora community, this is something that we've observed, and it's even more prominent in Cameroon, because if a child is out, for example, within the community, and let's say they are one of those who has challenging behavior, and they kind of drop down or are asking because they will be insistent, then the parent will be looked upon as a bad parent. They do not know how to parent, or that they haven't brought up their child properly. Apart from that, you also have all these sort of looks and making of faces, which in themselves may be an indication, could be read as an indication that you are not welcome here. And this in itself, though it is not, some of that is not done intentionally, that can be very difficult for parents to deal with. Mixed with that as well, we have social exclusion. You find that a lot of parents with children of living with autism can be socially excluded. I talk about the situation where, in a number of cases we've had, where there are a party or something, and one child is invited, a birthday, for example. The child who lives with autism is not invited, basically because of the fact that they will be seen, or because they may be a bit clumsy and push things around there, they will be seen as naughty or not really deserving of that invite. It's the same for their parents. We've had situations where a lot of the parents that we deal with, even ourselves, we've not been invited, and say, oh, well, we know you are busy. Most of the times you are occupied with the child. It is important in such situations to invite the parent, invite the child, let the parent say, no, we are not able to come along. But if you just assume that that's not the case, the parents actually, a lot of the times, being in these gatherings are very, very good for them. They boost even the morale of the child. We are talking about social interaction. How are they actually going to learn this, grow out of that, if we exclude them and not invite them? And this goes for even for the siblings as well. The reason why I put up the siblings there is because our kids, our youngest, sometimes when we are out and about, we've been out to things like functions, and we've basically had to say to him, go and play with your friends, because he recognizes that his younger brother, his elder brother, needs help, and most of the times he knows that he doesn't have a sense of danger and all that, and he would scout around and look at what he's doing and would want to run to mommy and daddy, which is what the siblings would do, and they miss out. So it's really one of those things that, as a community, it's important to recognize, particularly, that these parents will go through that. Exhaustion. I said I'll lump that in, but I think it's something to stand on its own, in the sense that for some of the parents, we know, particularly most of us here are parents, and we know that parenting in itself is very challenging. And what more of actually having a child with who also has challenging behavior and has extra needs. You get exhausted because most parents, some of those that we deal with, it's round the clock ourselves. You may have a child who doesn't sleep well at night. Even sometimes they have medication, they wake up at night, because you know that they cannot be left on their own. You are up, and you have to sit with them. Round the house, you have to keep moving things, especially where they have no sense of safety. And this in itself is very, very exhausting, to such an extent that it becomes very difficult to settle and have a few minutes without actually running around to see where the child is. For parents and siblings as well, it can be quite challenging that they lack time for themselves. And this is something that a lot of our parents, we've experienced. Apart from being the father to an autistic child. You are also a husband. You may be a wife. You may be a grandfather. You may also be the siblings, brother and sister. They need time as well. They need time for themselves. And if they spend all that time, with all those challenges, then ultimately they are going to be exhausted. They are going to end up with maybe a mental breakdown or things like those. So it's important as well, which is one of the things that we say to parents that we journey with. Find time for yourself. As a couple now, we tend to now go out. We don't want to miss that. A young man would enjoy himself. He would dance and, very expressive, and we'll do that with that child, with him. And, our community, especially those around where we live, they know him, they know what he likes, and would virtually celebrate that with him. I talked about social exclusion, and there is a story that most of my presentations I talk about, which is key to me. We've attended a few functions, and there are people just counting on us, looking at what we are doing, looking around, and what happens? You turn around and they turn their eyes away. In this particular case, there was a lady who kept looking. We were dancing with our young man, handsome young man, and at one point, when we got up to leave, they basically ran out to me in tears, and they said to me, can I give you a hug? And it was the youngest who asked him, turn to me, because I was already heading to the car. I said, Daddy, I looked around, and she said, are you okay? And she came to me as well, gave me a hug, and said she'd been observing us in that hall, dancing to every music, the one that I didn't particularly want to dance. If the young man enjoyed it, and he comes and says, let's go and dance, Dad, let's dance, Mom. He doesn't talk, but he will get you. And she said she'd been observing this, and she told me a story which melted my heart. She said her friends had actually contributed money for her to pay someone to look after her child at home so that they could go to a party. And some of these situations, she cried, and there she kind of was blaming herself. And I said, no, you don't have to blame yourself. But it's also one of the things that I said to her, the child did not ask to be born. We are those parents. Despite those challenges, this child needs to go out. It's also liberating for the child, which is one of those cultural aspects where a child with autism would best be locked away, not seen, and little or no interaction. So it's very important that we recognize some of these challenges, but also one of those things that I said, and I will keep saying, particularly when I speak to an audience where you have people like medical practitioners, it would also be something to think about when you are in your practice or you have the chance within your communities to just, look at that, because I know that we talk about health being a sort of holistic approach. And these things are very important, especially if you are seeing parents who that are looking after children who are autistic or may have other disabilities. Right, can we move on, please, to the next slide? Right, the last thing that I really just want to talk about is a few reflections about my hopes or our hope as capabilities for the future. I think my co-panelists have already mentioned some of those. One of the key hopes, particularly within our community, is that we are actually going to continue. We have this webinar because we want to educate our community about autism. It's one of those hopes that I'm kind of thinking that it would continue, and the more education we have, then a better understanding, and then we would be able to find that people are who live with autism are dealt with a bit better. They are kind of catered for in the manner that they should be. The other hope actually is that, particularly within the Cameroon context, is that there are actually going to be situations, a well-developed and properly funded government program in schools in hospitals and that specialists are going to be trained. We know that our co-panelists are already doing, some of them are doing a fantastic job in Cameroon, talking to professionals who are not specialists in that area and sharing insights with them, which is very important. Last but not the least, it's really that we as a community, as I already mentioned in some of those, would be able to be each other's keeper, because you know we say that it takes one person to have a child, but it takes the community to bring up and educate the child. So thank you very much for having me.
Wonderful talk, Giddeon. Thank you so much for sharing with us, you know, your lived experiences, and really, really useful to hear these. Following up on what you said about sort of being able to basically take your child out to a party, you know, like you'd want to do. I mean, I know several people, several friends who have children with autism, and I think, you know, the more there's one that comes to the party with her child all the time, and they get used to us, don't they? They get used to seeing their aunties and their uncles, and you know, we know what to do with them, and it all becomes normal. It's all about normalizing it, making them not feel like they're people that need to be hidden away. And I think that the more we have talks like this, the more we know, listen, it's not the child's fault, like you said. The child did not ask to be brought here. What can we do to support the child? When the parent has brought the child out, we should be there as a family. And I think I'm happy to say that I'm seeing that a lot more in some of the parties I've gone to, some of the communities where some of the parents are feeling braver to bring their children out, because they feel like, you know what, this is something normal. You won't keep your child at home that had diabetes or any kind of other condition, you know. So, you know, so I'm really touched to hear that. Now, I did have a question that came in earlier on, and it was both addressed to you and Dr. Qureshi, and it says, Mr. Giddeon, Dr. Qureshi, are there special institutions / schools for autistic kids who need education post-primary school stage? What support does the UK government provide to children with autism? And do you think that the UK government offers enough financial and postural support for the families? Very long question there. I don't know if you both want to share the answer, answering that.
Shall I start with the school question, and then maybe Giddeon, you can go on to the financial aspect from a parent perspective. So from a point of view of, so if the question is there specialist provision past primary school?
Yes, yeah.
So there is, yes, there is. And it may not be, it really depends on the needs of a child. So it might be that a mainstream school can manage with additional support put into place, with a diagnosis in place. So there are different levels, and as Mr. Angafor said, it's very different between each health and education authority as well. So I can speak something of the West Midlands, but here we have specialist provision, primary and secondary. There is also some specialist colleges, actually. There are mainstream schools, and then there are a mainstream school with resource bases as well, that sometimes are useful for children who fall in a place where they can access mainstream education but might need some specialist support intermittently. So there are different things available. However, accessing the appropriate resource for your child is not an easy thing to do. And as you spoke about litigation, going through the EHCP process, I have so many parents who tell me how difficult it is. But what I would say is stay strong and stay with your support systems and talk to the relevant people, because there is support at every level out there, but accessing it can be quite challenging at times.
Thank you, Dr. Qureshi. Giddeon?
Yes, coming back to the financial support as well, again, it is quite challenging, because depending on where you are, there might be better, what you call better services compared to other areas. So once they've gone past secondary school, obviously getting into the young adulthood, then it changes to the sort of adult team. Then they are assessed differently, and it may be in situations where they will have to live on their own or be looked after by social services or the local authority there. There is some support, but obviously we know at the moment how things are going. And some of these is actually means tested in many situations, as we know that things are gradually being squeezed at the moment, and councils are struggling with budgets and all that. So it really depends at what level and at what stage. But as Dr. Qureshi said, it's something to keep pushing, and in many cases you will have to push and push and push.
Lovely. And can you just say your foundation, does it help people to kind of signpost them to?
Yes. So yes, Canability's our core service is signposting to different services, and also saying, you know, this is the way, and helping just to talk about, as I said, some me time, because befriending is actually part of the journey, especially where parents are stuck and not sure of where to turn.
And may we have a link to your website, or to put in the chat to be able to contact you? Would that be
Yes,
possible?
I had the last slide had a couple of resources, and it's there, but I can put it on the chat. Yeah.
Yes, I think that would be really helpful. Now we've got a question from a fellow parent who says, my daughter has ASD and tends to look away every time when I try to introduce something new to learn. Any tips on how to manage this without getting too frustrated?
Right. If I start with that, I think there was sorry, I didn't put that on. There was actually a comment here before about triggers and some of those challenges. Yeah. If you know what they like, in a lot of the cases, if you want to introduce something new, they may like a TV program or may like a song. So if you are able to start with that, which calms them down, and the moment they are calm and excited, you introduce that, maybe bits, pieces of that. That can be very helpful, because sometimes things like those, things that are very calming to them, situations or environments that are very calming, if you use that actually as an interlude to introduce something new, they may well, or do that in between, do that for a bit. When they are being frustrated, you bring that back, and that in itself can help them to concentrate for a bit. But also, in a number of those situations, don't push it, and don't put it for too long. Try it in chunks and see how that goes. Just one of those things to try.
Wonderful. Thank you so much. Just to tell our attendees that we've got a Survey Monkey link there. We would be grateful if you could complete that. I know we're kind of running out of time. We did start a bit late. I think that we would like to answer as many of your questions as possible. So if that's possible, we'll continue for another 10 minutes while I whiz through some of the questions in there. And I would like to invite all our panelists to answer whichever one gets to them. So Jules is saying he hears that the speaker is mentioning that autism isn't something that can be revealed through a blood test. It's genetic testing, which some health professionals often use to confirm mutation in one of the chromosomes, not considered as testing. And actually following on to that, someone else is asking whether, given the genetic component of some of the conditions in ASD, are premarital screening services responsible to detect potential genetic deletions or duplications, such as couples are disadvised against marriage, similar to sickle cell disease. So basically, should we be doing some kind of prenatal testing for those that are at risk towards them? So Dr. Qureshi, Dr. Kilo, any responses to that?
So from a point of view, yes. So I mentioned that you can't do a blood test, but there can be a genetic component. So Currently, there are multiple genes that can, so your genetic code is like a book, if you like, and there can be, there are multiple genes within that can be associated with autism. And what we're realizing is that in certain developmental conditions like autism and ADHD, these genes appear more often. But it's not like Down syndrome where you have a chromosome difficulty where you can identify it very clearly. Now, there are children who come to my clinic where they may have some additional features where I do a genetic test called a microarray test. And when I do that test, there may be a small genetic deletion or a small genetic duplication. So a little bit of a spelling mistake, if you like, in the genetic code. Now, when these are analyzed by the geneticists, they may have a higher frequency of association with autism type difficulties. So currently, those are minimal. So if I test, the last I heard, it's something like, you might 20% of children may, and you're testing a specific cohort, you're testing children that are coming to your clinic. There's not many that are going to come out with a very specific genetic deletion or disorder. However, related to premarital discussions, what I would say is family history is linked. That's an important thing to keep in mind. Advancing paternal age is linked with autism as well. So there are certain aspects of this that may give you some clues. If it is known that in a family there is this genetic microdeletion, then I suppose that could be something to consider. But we don't even, I don't know how it is in the USA. It may change here as well, but currently we don't necessarily test every child who comes to our clinic with a genetic microarray test. And you can very clearly have autism without any difference showing up in your genetic code.
And just as someone whose patients are going to come and ask me, if someone comes and says, I've done some research and I would like this genetic micro array test, what should I be saying to them?
So presumably, would this be a patient who'd seen a pediatrician?
Yes, or maybe not. Maybe they've just gone and Googled and said, "Oh, there's lots of autism in my family. There's lots of autism in my other house family. Can I get this test? I Googled it. I watched the CamDoc webinar, and Dr. Qureshi mentioned that. Can I have it? What should I say to them?"
So it doesn't work like that. Currently in the UK, it's quite targeted. So if a family came to me and I could make a clinical decision that a test is required, then I would do it. But if they are under a pediatrician and the family have this query, you could refer it back to the pediatrician. Perfect. And to be honest, it's not something I would need a lot of persuading to do. If there's a strong family history, I would organize it.
Wonderful.
And when you organize the child's test, if a difference is found, we then automatically will test the parents.
Perfect. We had a question earlier on from Masambula. It says, is visual impairment and problems with color an issue with patient with autism spectrum? Where can we go to assess these issues?
Is this in the UK or?
I think Masambula is from the UK, so he's probably asking from the UK perspective.
So first off, I would start with a optician test. Then, if required, you can ask your pediatrician to organize a specialized optometrist test. Sometimes I might refer to specialist eye departments. Visual dyslexia is something that can be tested from, I think, 7 to 8 years onwards. But again, services are patchy. There aren't always specialist clinics that you can refer to for these assessments. Interestingly, though, I think some opticians with a payment will, depending on the ability of the child to engage in these testing, are now offering, there are some specialist opticians for private fee that may offer specialist testing, but I would say go with what's available first off and see.
Wonderful. Question from Erica, who is a doctor. I think she's she's in the US and she has a child with autism. She's asking, at what point or stage do we involve the various parts of treatment, that is speech therapy, physical therapy, etc.?
Absolutely. Absolutely. So from the moment you have concerns, if it was the speech delay, that was the first thing that had that eyebrow raised for you, and you're like, maybe there's something wrong here. Once you go to the pediatrician, the first thing that gets ordered for us here, and I can speak for where I work is that the first thing we do is we put in referrals for speech evaluation, occupational therapy evaluation, and any other things that are ongoing. So those two things get started first. Those are the first two things, or a few things that you would have to start before the autism assessment, because the evaluation for autism, that appointment is not going to be tomorrow. It could be a while to get to it. So at least start things, start the speech and the occupational therapy and physical therapy if the child needs it, feeding therapy if the child needs it, start those things immediately.
Okay. And is it possible for autism to be masked and not be diagnosed till the child begins school? If so, is it too late at that point since they are older?
Yes, it can be. I don't like to use the word masked, so I will not say masked, but it could be unintentionally overlooked based on what the child has presented with. And so, yes, that is absolutely possible. Some kids we get in middle school, most commonly, the girl child is the most common time when we get them to come in for the assessment, because that's when the social challenges are, or the social demands are greater at that stage in life. And so that's when we get them. Absolutely. It's never too late. I honestly don't believe in it's too late. You just might need more time. Maybe if when they were younger, you could have, if let's say you needed a maximum of 20 hours per week, this is just an example, 20 hours per week to do therapies for a child who was much younger. For a child who is 10 years old, you might need 40 hours per week. And being in the US and having all those work schedules, it might be challenging, but it's never too late.
And question for Giddeon, could the panelists, could you discuss and reassure, I guess for all of us, could we discuss and reassure parents who can be conflicted with asking for or accepting help or respite because they feel it's admitting failure or abandonment of their duty to look after their child?
Certainly, I can offer a few thoughts about that. I think it is not or should not be seen as a failure. First and foremost, the child deserves, and the parent as well, it is a service. And the child and parent deserve that service. First, it gives the child a chance to go away from that home environment. It gives them the chance to be somewhere where they can actually be looked after by a trained person other than the family, to have a break, because, you know, getting out of the familiar environment in itself can be uplifting. And the child going to that respite where they have a well-tailored program for them also gives that child a break from the familiar home surrounding. They do something else that they love there, but also for the parent, it gives them the chance to re-energize, kind of recharge their battery, as we say, and be ready to go again. So it shouldn't be seen as an abandonment. These are services that the children and parents are entitled to. So you cannot be seeing what you are entitled to as a failure. So let's think about that.
Yes, excellent. I did get this question again. I had a few questions sent to me beforehand. This is a personal one. He writes, I'm the parent of a 23-year-old with autism, ADHD, and learning disability. Like most parents, I'm somewhat a specialist of my one child. I'm now stuck in trying to explain the abstract concept of dreams to him. He is struggling with challenging dreams. Any pointers?
That's.
You want me to go?
Yes,
go on. Yes.
Yes, please.
Absolutely. The best way I can sum that up is if they don't learn the way we teach, then we teach the way they learn. And so understanding abstract concepts can be quite challenging. And so you have to find other teaching methods that works for your child, because that one child that's yours, you are the expert in that child, like you rightfully said. And the one thing I always encourage parents to do is, one, know the child that's your child, know who that person is. Two, know the diagnosis. You've listed autism, ADHD, and LD.
Yeah.
So know those three things And 3, know the child with the diagnosis. So once you know all those 3 things on those 3 categories, then you've mastered your child completely as a whole, as a person, as one factor. And so you have to introduce it. Abstract concepts is hard, whether it's typical or non-typical people, it's hard to learn. Don't get me wrong. Even myself, it's hard for me to learn certain abstract concepts. But when you have a child with this challenge, then you have to find the way that this child learns and use that. Only you can crack that code, but you can get help to crack the code.
Wonderful. And our last question for the evening, what are the chances for autistic children in the job market / employment / academic world? Do they have the chance of getting into professional jobs like medicine, law, banking, etc.?
Yeah.
I think it's very much dependent on the individual profile of each young person. And absolutely, if they are able to do a job, there should be, like I said, they should be covered under legislation, and reasonable adjustments need to be made, particularly to help them engage in that job. However, I do counsel young people about sometimes when they ask me about the future. And I think you have to be careful when you're taking something on. Even if you're able to do it academically, you have to consider the other aspects of the social impacts of a career. And I remember counseling one very intelligent teenager who came with both his parents, who were both doctors, and they were really scared because he wanted to be a doctor. And they said, he can barely manage, he's incredibly bright, but he comes home, he shuts his door, and he can barely talk to anybody. So I discussed with him, I explained to him what a day in the emergency department is like. And I said, do you think that would make you feel that you're using your skills, or how would you feel about that? And he said, I find it too stressful if I had to talk to new people all the time. So I think in the end, he ended up wanting to be a research scientist, and I'm sure he's going to discover something amazing. So I think that it's very much on the profile of the child, and as Dr. Kilo was saying, knowing your child, knowing their strengths, knowing the whole thing, I think is really important. But yes, if they can do the job, they have the ability to do the job, they shouldn't be held back from potentially doing that.
Wonderful. Giddeon, you wanted to say
Yes,
something?
I just wanted to chip into that. As it said, depending on the person and their ability, yes, they can. There are already a lot of moves across different businesses and different departments to help. As I mentioned, like in the neurodiversity group where I sit, it's out actually advising and helping to shape how employment for this can happen. Some of them may be very intelligent, but going through interviews would be difficult. So some of these, we are looking at situations where interviews can be scripted, given to them. They look at that, work on that. We know their ability, but we know that they will be very anxious to sit and answer interview questions and things. So it's about those reasonable adjustments, but also structuring their workday so that different tasks are actually specifically structured and say, do X, Y, because a lot of them can follow instructions very well, where they are capable of doing that. So yes, they can, but again, it depends on, how those sort of the profile.
Wonderful. Dr. Qureshi.
Yeah, I just wanted to mention one thing. We've talked a lot about what can help, and I'm very aware currently when we talk about resources in this country, resources are really strapped. And I think the American system is different, where you can access early, depending on your insurance, I presume, you can access early interventions. So one of the hardest part of my jobs currently is explaining the waiting lists to families. Not something I control, but it's really heartbreaking. So I do want to say, I just wanted to highlight that, not to be negative, but I appreciate this is a real obstacle for families as well. But what we are told when we are raising the fact that families are, facing these waits, is that actually through nursery, through education, through the health visitor, there should be some support put into place until a diagnosis is verified or a specialist school is identified and that sort of thing. But that is one of the major obstacles currently in the UK.
Yeah. Are there any options privately if one were to choose to go privately?
So parents ask me this. They say, if you could advise us. Now, I'm not really supposed to advise anything specific under the NHS, but what I do understand is, in my locality anyway, communication therapies are incredibly strapped. So if parents have the means, sometimes they do access speech and language, specialized speech and language therapists, because they say they do find it a bit hard to know where to start with the communication side of things. But yeah, we're not supposed to advise, and we always advise, if you do go for someone, then please make sure they're appropriately accredited.
Exactly. Well, I mean, it's 8 o'clock on the dot. We were meant to finish at 7:30, but I'm sure you will agree that it was really important that we spend that extra time to talk about what is quite a very important topic. So I'd like to thank my panelists again, Dr. Kilo, Dr. Qureshi, Mr. Angafor. Thank you for being here with us and giving us your time. Thank you for speaking so passionately about something that you quite obviously care about. I would also like to thank my backroom team. I didn't introduce myself at the beginning. I just started speaking because I assumed everybody knew me, but I'm actually the chairperson of CamDocUK. I do have my very able communications secretary, who I don't think we've ever run a webinar without her, because I don't think any of us know how to manage the Zoom. Her name is Dr. Anambene. She's somewhere, and maybe she'll show us her face soon. And she's been at the background spotlighting everyone doing the polls. Dr. Valentine Gua. Well, you guys, show your faces, please. Dr. Valentine Gua, who's our education lead, and he usually is the lead with all of the webinars. He's also here. He's told me to inform you that our next webinar will be in January sometime, and we will let you know about those. Dr. Morgan has been behind the scenes writing to you in the chat, putting all the websites in there as well. And you know, without her, we won't be looking very as nice as we do on the video, because she's been making sure that we have been using them appropriately. There's Dr. Mbene. So I don't think I've forgotten anyone. Dr. Christian, he is the one who did our webinars. Oh, hello, Dr. Morgan. Thank you. Dr. Morgan, Dr. Christian Akem, he did the flyers. He's usually here, but he's in America at the moment. So, and I want to thank every one of you who attended today, who shared. All of this is going to be, it's been recorded. So you're going to be able to watch this again on YouTube. When you do watch it on YouTube, please share it with anyone that you think might find helpful. On our website, www.camdocuk.org, there is a button where you can ask us questions. So if there is anything about this presentation that you wanted to know about, if you wanted to ask us a question, if you wanted us to ask the panelists a question on your behalf, we can ask them. So please, I hope if there's one thing you've taken away from this, autism is not a mental disorder. Autism is a different language that your child is speaking. Sometimes some of us may not understand that language, but if you bring us into your child's life, we can understand that language with you, and we can make your child enjoy the world as they are supposed to. So on that note, full of hope, your child can be anything they want. There is support available, even if you have to wait. But you know, let's go away being positive about the future for our children. And again, thank you